We're live now, Chair.
Thank you. Agenda this evening. So it is also the last meeting of the committee before the elections. So we'll just go on with the agenda, and the first item, any apologies, Adam?
No apologies received, Chair.
Did we not get one from Councillor Pat Wright?
Yes, thanks, Chair. I'll add that into the minutes.
Okay. Any, with the code of conduct, any declarations of interest that anyone would like to make at this point? Okay, thank you. And just the minutes of the last meeting on the
Chair.
There's two sets.
Chair, sorry, it's Councillor Wheeler. Sorry, I forgot to unmute myself. Declarations of interest. Just declare that I'm employed by Mersey Care NHS Trust, which will come up under item 9, I think. No, 8 and 9. Thank you.
Judith. And then the minutes of the last meetings on the 28th of January, and then also the meeting on the 23rd of February for the spinal services meeting that we had. Any comments on the meetings or the minutes? That's all.
It's Lucy Gardner from Warrington and Holton Hospital. Sorry, I can't raise my hand. Could I just raise 2 points of accuracy, please, on the minutes?
Certainly.
Just on page 8 of the pack, the third paragraph down, it is just a typo, but it's kind of quite relevant. It says that the pick of COVID positive patients, I think it should say the peak. Got that one?
Yep.
And then on page 9, the third paragraph from the bottom, this was in relation to the plans for the new hospital. Third paragraph from the bottom, the development of a strategic outline case was ongoing. It was actually complete, and you'll see over the page we talk about the approvals that are in place. So if we could just make those 2 amends, that'd be great. Thank you.
Okay, thank you very much. Anyone have any more? I think at the bottom of page 6, Adam, the position provided within the update was as at the 27th of January in the 7 days to the 21st. That's the other one. But other than that, I think we're good to go. So thanks very much. So the next item on the agenda is the Town Deal Programme update, and that's Simon. Are you with us, Simon?
Chair, we seem to have lost Simon. I'm just trying to call him into the meeting. So if you maybe wanted to move on to the
Yes.
next item, and we'll
Okay.
see if Simon's able to join us after that.
Okay. Sarah, public health update. Are you?
Okay, thank you. I'm just going to share my screen with colleagues. Just bear with me. Okay. I hope that's come up. Adam, has it come up?
That's fine, thank you.
Super. Okay. I'm going to just give the situation report rather than go into too much detail about what we've been doing on this session, just because we need to pause. It's, you know, we're a year on from when we entered national lockdown, and we're about to start easing up again from our national lockdown. So, you know, where are we in terms of Warrington, and what is it that we need to be considering in terms of our COVID recovery? That's what I wanted to focus on today. So, you know, I'll be looking at through a bit of the surveillance data and what next. I'm not going to dwell too much on this slide, but if anybody wanted a snapshot of where we're at for Warrington, this is it. You know, in terms of our weekly case rates, etc. But I'm going to just present a few more slides just to give some you know, more depth to this data. You can see very clearly that a bit like I presented last time, you can see that the peak happened, a second peak happened in the beginning of January, and we're tailing off in terms of our trends. You can see that it's actually the latter part of the graph, it's fluctuating. The purple is fluctuating. It goes down some days, it goes up other days. So it's really, we're not going down any further at the moment. So just to distinguish, the pillar 1 is mainly NHS testing, and pillar 2 is community testing. So you can see very clearly from this graph how we compare with England and with the Northwest averages. And you can see that whilst we've come down, you can see that the purple line is still ever so slightly above most of the other lines, which is unfortunate. We were coming down incredibly well. We came down, as you can see, from the 5th of January. We came down quite steeply, but our slowing of rates is a concern. We are actually, compared to the rest of, oh, that's Stephen tried to call me, and compared to the rest of the Cheshire local authorities, we are much higher. So, our 7-day case rate is 79 per 100,000, whereas if you look at Cheshire East, it's about 58, Cheshire West and Chester 66, and Holton 58. Now, we mirror more of what's happening in Greater Manchester. Warrington mirrors that side rather than the Cheshire and Merseyside as we currently stand. Partly, you can see that the testing trends and who's been testing positive. It's actually quite an interesting picture. The number of people who've been testing, going for tests, has gradually reduced through January and February. During March, it's fluctuated between 355 and 376 per 100,000, and it's currently at about 369 per 100,000 per day, which means that we are roughly looking at about 770 people testing a day. That's quite that's an interesting picture. However, if you look at the positivity, we are very low in terms of our positivity. We're at just over 3%, which is well below the Public Health England threshold of concern. They get worried if you get 7.5% or over. And compared to the Northwest, we're still a little bit high. They're at 2.8%, and England is at 2.1%. So we're slightly higher than the England average and the Northwest average. What I would say, I'll just go back to the other one. Our lateral, so this is PCR testing. This is for people who've got symptoms. If we're looking at lateral flow testing, our lateral flow test, the rate of numbers of people who are going forward for lateral flow tests has doubled. So we're seeing partly the rise in cases is partly, not completely, due to the increase of lateral flow tests. Many of you will also have done the lateral flow test as part of the household bubble at school with your school children. You can see that the results of that have been coming through in terms of the testing rates. If we look at spread by age, if you remember, it's the light yellows that we're trying to aim for, and we're trying to avoid dark purples and blacks. And while we're not quite out there yet, we can't see much yellow towards the right hand of the screen, but we are getting much better. The blues are a promising sign, and we're seeing a little bit of a light green. Unfortunately for us and across the whole country, you know, the highest rate of increase is in the 10 to 19 age group. So in Warrington, our rates, our 7-day case rate is 129 per 100,000 in that age cohort, closely followed by the 30 to 39-year-old age group, which is at 121 per 100,000. So you can see that, you know, I've been probably telling you for the last few times that it's our 20 to 39-year-olds where we're seeing the highest number of cases. Well, that has just changed, and it would do, wouldn't it? Because we've come out of lockdown. Some people have come out of lockdown, and it's the schools and the colleges that have done that. So you can see that that picture, along with the lateral flow testing, is resulting in a higher case rate in that age group. From the 14th of March, cases have risen much more in primary school age children, although interestingly not necessarily in the high school age pupils. But yes, this is an emerging picture, and we have had several of our school settings with you know, more than one case and often more than 2 cases. So that's an emerging picture that we're watching and supporting the schools and our brilliant head teachers in that space. So if you're looking at the geographical hotspots, it changes. It almost changes on a weekly basis, if not a daily basis. Sometimes, you know, there are higher rates in Grafenhall, sometimes there are higher rates in Culture, etc. So you can see that the central wards, the east wards, you can see the picture broken down by ward. The good news is that everywhere, you know, all of the wards towards the right-hand side have gone up. You can see that the wards where there's been a slight increase, but we're talking about very, very small numbers. So even a small increase can show up. Even a small number of cases can make quite a big difference at ward level. So most wards have been fluctuating up and down, and there's no consistent trend. The 7-day ward rates, you know, range between 29 and 147 cases per 100,000. So you can see quite a wide range. And a handful of the wards have seen rises in rates in recent days. And the numbers are small, but you know, it does make a big difference. So the hotspot at the moment, and it changes, as I say, is Latchford East, but that could change tomorrow. I'll leave the hospital admissions to Simon and Lucy, but it's a much better situation. I'm not able to present much more granular detail about vaccinations, but you can see in terms of the wards where we're seeing some of the highest uptake of vaccinations. And this is priority groups 1 to 4, and it shows who've had the first dose of the vaccine. It shows some of the highest uptake is in places like Lynn North and Thelwell, and some of the lowest uptake is in Beasley and Whitecross. So that picture is changing on a daily basis, but that's where we're at. And we're seeing, I think Andy Davis is on the call. You know, we were just discussing before going live how some people are, you know, have, you know, we've reached the people who want to be vaccinated, and we're continually going back to the people who haven't come forward to check that whether they have been vaccinated. So as you know, it's 50+ at the moment that are eligible, plus health and social care workers and carers and various other cohorts like that. I just wanted to sort of end on, it links with the previous slide on vaccinations, because you can see a picture of inequalities emerging, not just with vaccinations, but with COVID in general. today, you know, the first a year on from when we went into national lockdown, what we've seen over the last year is COVID absolutely exacerbating inequality to incredible heights. I just wanted to show you this this particular graphic, which I think nicely explains when people say, well, what is the link between inequalities and COVID? I just wanted you to be able to sort of articulate what the links are, and this is quite a nice way of doing it. So this is work that Claire Bamborough has and others have produced, and it shows that in terms of exposure, as a result of inequalities in working conditions, and particularly lower paid workers in the service sector mainly, they were much more likely to be key workers, and therefore had to work during lockdown, and had to work, were more likely to use public transport. People in the lower skilled occupations are also less likely to be able to work from home. And if we look at some of the cases, some of the people who have been getting COVID, that's very much a picture of those occupations being more exposed. If we look at this from a transmission point of view, the inequalities in the housing conditions seem to be contributing to inequalities in COVID. So some of the more deprived neighbourhoods are more likely to contain houses of multiple occupation, people living, living in the same household, a lack of outdoor space, as well as high population densities. And also, it's really difficult to, we're told if you've got a case in the house, they've got to self-isolate from the rest of the household. It's very difficult to do that in a smaller space or in a house of multiple occupation. In terms of vulnerability, due to the higher burden of pre-existing health conditions, which already increases the severity of mortality of COVID-19, we're seeing that a lot of the comorbidities arise as a result of health inequalities, particularly the social determinants of health. And if we look at it from a susceptibility point of view, unfortunately, because of weakened immune systems over a period of a long time of long-term exposure to adverse living and environmental conditions, this seems to have an impact. And the social determinants of health also work to make people from more deprived communities much more vulnerable to infection from COVID. It's a bit of a sad slide to end on, but I just wanted to sort of bring that to the Scrutiny Committee, because we have seen a year where inequalities have absolutely been exposed, and they're likely to be exposed for many years to come. There are practical things that we need to focus on in our road to recovery, and we need to do that together. I'll pause there. Because I think there may be some questions, but also Simon, the work that Simon and the Newtown Deal work is doing is part of our hope and part of our recovery. Thank you. Stop sharing the screen now.
Thank you, Thor. Does anyone have any questions?
Hi, Chair. Lorna Pink from North West Boroughs. I'm awfully sorry, I'm only on the phone, so I can't put my hand up. Is it okay if I go next? Just a question.
Please do.
Yeah, thank you. I'm unable to actually see the slide, but thank you for describing it so clearly. I was wondering, from a mental health perspective, was that one of the groups that you've seen in terms of an inequality and impact, please?
Absolutely. I mean, this is what I've presented is national work, but it's very much, a picture that I think we're seeing across Warrington as well. And we're likely to see more and more of that over the coming weeks, months and years.
Thank you. I think that mirrors probably the pattern that we're starting to see as well in our services.
Chair, can I ask a question? Next. Paul?
Ask away, Sarah.
Sorry. I've got a question just about long COVID. I don't know if this is the right time, but I'll try. I just wondered, in terms of long COVID, the kind of numbers that we have locally, whether that's something that's being recorded, and also what kind of support is being given, because obviously it's, you know, it's a long-term condition that people are affected in a variety of ways.
Thank you. It's a good question. I don't have the numbers to hand. You know, perhaps somebody else on the call does, but what I think the difficulty at the moment is getting the information from people's occupational records, you know, into the GP records. I think that's probably partly why we haven't got, you know, fingertip data around an accurate picture. The definitions are often quite problematic, so it's almost as though you haven't got long COVID until you're 12 weeks and over, but actually that's quite an artificial definition. What we do have, and Simon Constable's on the call as well, we do have some clear referral pathways for people who have suffered from COVID, whether it's long COVID or not. So, and you know, the route through to any of that support is through the GP. You know, you get a GP referral, and then there's support for you if you've got you know, the aftermath of COVID, as well as more sustainable long-term effects.
Okay, thank you.
Any more questions for Tara? I have a couple then, Tara. Is there any pattern to, you were talking about the mental health implications of COVID. Is there any picture coming forward about the age groups, or is it across the whole of age groups that are being affected by mental health issues?
I don't have that data to hand, Councillor Warburton, but I'll certainly take it away and have a look if you want. I think it's going to be quite difficult to get an accurate picture, but Amanda's just said that she can advise on children. It'll be sector by sector that are looking at this. Is it okay?
Yes. Do you want to come in, Amanda?
Hi, Councillor Warburton. Yeah, so I don't have data to hand, but what I can tell you is that we are seeing an increase in referrals and an increase in joint working with our health colleagues around increasingly complex mental health difficulties, which have to be linked, at least in part, if not wholly, to the COVID situation, because they're over and above what we would normally see. We're also seeing an increase in physical abuse cases at the moment in our referral patterns. So yeah, there's definitely a pattern there for children in terms of increased emotional and mental health issues. I think just generally for families, where we're up to with, you know, this stage of 12 months into in and out of lockdown is causing incredible family tensions. There is work going on across the partnership about how we respond to that, but it is a real issue for our children in the borough at the moment.
And you say that it's increasing physical abuse. Is that within the household?
Yeah.
Families, or is it outside?
Well, I wouldn't know about outside the household. That would be police data probably, yeah. But within families, or contextual issues maybe would come to our attention. But within families, it's increasing, and what we're tending to see is one-off incidents where we've never known a family before, and they've just reached crisis point at that moment in time, and probably we'll never hear from them or see them again once they've got a little bit of support in place. But families are really struggling at the moment.
Mm. And is there any means of identifying before the crisis within the services that we offer?
I think it's been very difficult when lots of children have been out of schools, because that would be most of the eyes and ears on children. I'm finding it very interesting and I don't know what the answer is as to why, but I'm finding it interesting that it's happening after the children have gone back to school, not while they've not been there. Although, as I said when I said that earlier on in a meeting today, it might have been happening at home, but from what the children are telling us, in a number of cases, it's the first time that this has happened. It's just a bit of a house is a bit of a pressure cooker at the moment for people, feeling like that, you know, they're cooped up and they've been the next pause in lockdown can't come soon enough for our children and our families, I fear, and just hope that we get there quickly, really.
I would have thought the opening of the schools would have made a difference, because it was a bit of a relief on pressure in the household, but I suppose there's so many individual variables, it's very difficult to judge.
I think what we're finding is that children have gone back to a bit of normality and a bit of increased expectations around the learning, and if they've got some difficulties with that, or if they're finding school frustrating or just the change frustrating, they're coming home, probably responding to parents differently, and then parents are still in a place where they're still in lockdown, and it's just a lot of tension around for people, and, you know, very sadly things happen in the heat of the moment. Yeah.
I was just wondering how it could be headed off. Well, I suppose you're right. The schools are can judge it early on, I suppose. It's important that there's lines of communication as well.
Schools and early help colleagues and getting in early doors where we know that families are struggling is absolutely the right way to go.
Yeah. Thanks very much,
Chair, it's Lorna Pink. Just to add that we have our mental health schools teams too in Warrington now, and they're getting increased referrals, but they can definitely support schools in this situation. And our CAMS also our crisis CAMS team have seen a big increase in referrals since schools went back. So we're seeing the referral pattern midweek rather than at weekends. So I think to just, you know, reflect what my colleagues just said, it's that change and that coping with going back to school again as well. Yeah. So it's protected, but it's also put pressure on the children in other ways.
Yeah, I suppose it's the trying to prevent the crisis occurring, and that's the trick. And I think when we have these conversations, it's really interesting to hear about these unseen services that the council continues to offer that nobody really knows about, and it just goes completely unseen the majority of the time. So yeah, thanks very much, Amanda. Thank you. I was also going to ask Tara about the long COVID services and whether or not once they've been referred to the GP, what sort of support is in place. And it may be something that comes up later, or maybe somebody else will come in, but there was somebody had contacted me regarding somebody who'd been in hospital for a long period of time. They've been ventilated in intensive care, and they didn't realise that they'd got so much better, and then they came home. They've got some temporary care that's going in, but the family are really struggling with the physical requirements, but also the mental stresses of having somebody that's convalescing from very serious illness. And of course, the person who's convalescing just doesn't feel as if they're making any progress. So what sort of support is put in place?
Okay, I think what I'm hearing from you is something beyond the more formal pathways, isn't it? So the support for carers, reaching out as well, and I think that's where you know, Andy Davis and Simon Cuthbert on the line. They may want to talk about the formal pathways, but it's the the community and voluntary sector have stepped in and are supporting people to signpost them to the support that's available. Certainly people in my team, it's Stephen really wants me, and it's you know, people in my team, the wellbeing service, they've been reaching out to people, especially supporting them if they know that they've got particularly debilitating conditions. I'll pause there. I think Simon wants to come in.
Yeah. Andy Davis, would you like to come in?
Sorry, Andy. Because my microphone's on top of my head. There you go. Was being good. So we've got access to a variety of options for people, particularly if they've needed support. So anybody who presents with COVID symptoms may be offered a pulse oximetry at home, which puts them onto a home management pathway, and they can get support and access support through that if they've been unwell. Obviously, there are some people that are admitted to hospital, and they may be assessed or and either discharged home to the COVID at home service that's run by the respiratory team, or maybe discharged after a period of hospital stay to the COVID at home team, and they'll get monitoring and immediate support and follow up as a result of that. The hospital have also worked with us on producing long COVID clinics through the respiratory team again, and those are available to patients who have significant long COVID symptoms. And then there's a bit of a grey area of people that aren't quite right after COVID, and they're offered a range of wellbeing or other offers, and that's probably the bulk of the long COVID symptoms and probably the least well understood bit. But there are offers that are more about helping with the symptomatology rather than getting under the problem, because we're still not quite sure of what the problems are that lead to some of those symptoms.
So what sorts of support would be in place if somebody has been discharged then within the community?
So if they need specific support for COVID, then they've got access to the respiratory teams for breathing problems and other things. There's physical therapists, district nurses, wellbeing advisors that can help them access a whole range of services across the statutory sector or third sector, looking at things all the way from mental health and wellbeing right the way through to physical help and assistance. So there's the good packages, and I think people are accessing them well. I suppose the bit that we're struggling with is what are the therapeutic interventions amongst all of that support, because, as I say, we don't know what the underlying problems are that are contributing to the symptomatology. So it's more support at the moment that we're able to offer. Part of the long COVID clinics that are ongoing at the moment are to contribute to a body of knowledge to help understand what might be the useful therapeutic interventions going forward. And at the moment it's empirical, so not an evidence base, but trying interventions that should help as that knowledge base builds.
Okay. Thanks, Sandra. Simon, did you want to come in and add to that?
Thank you, Chair. Just to add to what Andy's already said, I think in terms of, as Tara's already characterised, we're still in the sort of foothills of understanding this virus, and the definitions are quite arbitrary around post-COVID syndrome and long COVID syndrome. So I think Andy's already described, so for patients, for instance, that are admitted to hospital that require specialist follow-up, that's undertaken as part of the follow-up. So for instance, critical care patients or respiratory patients. One thing that hasn't been mentioned, I think, well, two things that haven't been mentioned. Firstly, around the real specialist capability that's on offer through the Liverpool University Hospitals and their infectious diseases unit for those very severely affected patients who really we're not sure how to manage. And secondly, the importance of research in this area, and with the opening of the recently the Holton Clinical Research Unit, hopefully we're going to participate in some long COVID research there to do the very things that Andy's talked about in terms of providing some evidence base behind the interventions that unfortunately are going to probably be required for some time.
That's great. Thanks very much. It's interesting this week as well that there was an item about, I was talking to one of a nurse that I know, a diabetes nurse, and she was saying that significant increase in referrals for diabetes post-COVID. And it's just, you say, we're learning all the time, and it's not something that had been out in the general domain, but it's out there, you know, it is happening. So thanks very much, everybody, for your contributions. Anyone have any further questions for Tara just before let's go and answer a phone to Stephen?
Paul, hi, it's Councillor King. Sorry, I had to dial in. The application's not working.
Okay.
I just wanted to ask a little bit more about the long COVID piece. Thanks, Simon, for elaborating a little bit more, because that was my question. But it's a really important concern for communities and anyone that's got COVID and continues to get COVID. We haven't really, although there is something in place, they haven't really touched on that is, apart from this Holton critical unit, as you just mentioned, which is great. But the long COVID is going to be a subject matter that's going to continue to rumble on. And actually, do we really know if people have got long COVID or just a condition based upon the fact that they've had COVID? So how do we classify it? How do we help people that have got it, and how do we help the community understand that if they get COVID, there is services afterwards? So what's happening in that space? If you just give me a little bit more than what we've already had, that'd be great. Make sense?
Simon, do you want to
Do
come
you
in?
want me to come in?
Yep.
So
Thank you.
I think I can start to answer that question. In terms of at the moment, as I said, the definitions are quite arbitrary. At the moment, it's described as a post-COVID syndrome can be up to 12 weeks, and a long COVID syndrome is beyond 12 weeks. Now, it's a very heterogeneous group of symptoms patients are presenting with, and so consequently, of course, it depends on where they are is the best source of that. And for the most part, of course, it's their GP, it's their primary carer that's going to be the source of initial assessment on all of that. I think it will be beholden upon all of us, some of which are in the room now, to adjust our developments in terms of longer term care around COVID. You know, thus far, of course, the needs have been largely around the acute care, around testing, triage and assessment, and around acute care of COVID patients. But I think inevitably, as we get on top of the acute issues, we will need to amend our services accordingly to, we're you hear in the media even all the time around new syndromes that are emerging, new symptoms that are becoming more characteristic of post-COVID or long COVID syndromes that will need to be investigated, and our services will need to be amended and adjusted accordingly, and capacity adjusted accordingly. So I think this chapter of the book is as we've already suggested already this evening, is far from written.
Thanks very much, Simon. Is that okay, Amanda?
That's fine, thanks, Paul. No more questions.
Okay, I think also the importance of public health is really reinforced by the whole of the COVID experience, really, and continues to show that we need to continue with public health and invest in it heavily. So thanks again, Tara. That's very, very useful and always very informative. So we'll let you go and answer the phone to Stephen, and that would be great. Thanks very much. So we go back to Simon Kenton, and he's going to talk to us about the Town Deal programme. Just give us an update. Are you with us, Simon?
Thank you. Thank you, Paul. Can you hear me?
Yep, far away.
Thanks very much. Apologies for that. I've had to dial in. So what I wanted today was just to give you a very brief overview, the background in relation to the Towns Fund, try and enthuse you to get involved. First of November 2019.
We're struggling to hear you, Simon. Is anyone else struggling to hear Simon?
Yeah, I've lost sound.
Can you hear me?
Very intermittently.
It's a very bad line.
That's great. Okay, well, I'll keep it short. Stick my head out the window. Is that better?
Yeah, I don't know. Yes, we can hear you. Keep talking and we'll tell you.
Okay, so a town deal board was set up, and we created a town investment plan with a collaborative approach, so everybody was involved. It very much linked to the Central Six partnerships, where people will hopefully acknowledge a great deal of engagement and communication took place. So we presented initially projects over 4 areas: education, transport, economy, arts and culture, and health across them all. And we initially bidded for £26 million, and we were told in November that we were one of 7 to be awarded money from the first cohort, which was £21 million. And the paper, which, apologies, was late coming out, sets out the 7 projects which have been identified as taking us forward. Those 7 projects include a health and social care academy, which will be led by Warrington and Velroll College, a town centre health and social care hub, which will be led by the hospital, a construction hub, again led by Warrington Vale Royal College, sustainable transport programme, a digitalisation hub, and relocation of a bus depot. And included within that is a remastering of Parr Hall and the Pyramid. So all of those programmes are mutually connected, and we need to create some synergy between them. It's fair to say, as being one of 7 towns, we are having to tell the ministry what the problems are and what guidance we need, and that's been very they've been very slow to respond to that. But you'll see those 7 projects, there's lots of synergy between them, and they have a potential impact to really help us deliver our public health agenda and the agenda of our collaborative approach, which was Warrington Together. I'm sorry about the communication issues, but I hope that's helpful.
Thank you very much, Simon. Does anyone have any questions for Simon?
Chair, it's Lucy Gardner from Warrington Holland Hospitals. May I just add something to kind of link some of what Simon was describing to the previous concerns around long COVID and the impact of COVID, just in terms of the health and wellbeing hub? I think it might be helpful. So we've just had our first health and wellbeing hub delivery group meeting today, and part of that discussion was around some of the services that we're planning to provide. And I think what's really good is it gives us the opportunity to respond in a really coordinated way across multiple organisations to some of those challenges that we're seeing kind of as a result of COVID. So, for example, diabetes and mental ill health prevention are 2 of the things that specifically we've discussed as being part of that provision. So I just thought it might be helpful to make that link to the previous item.
Thanks very much, Lucy. That's very helpful. Anybody have any further questions or any points to raise?
Yeah, Paul, can I just ask, in terms of timescales for delivery, is it set in stone, or how long do we anticipate a lot of this is going to take to be delivered?
Well, the funding's over 5 years, but we have to go back to the ministry by the 17th of November this year with business plans. It's quite a convoluted process. So the council will be responsible for passporting the money, and we need to have grant agreements with our delivery partners to ensure that they deliver the outcomes. We've identified 4 projects which should be ready earlier than November. Business cases should be earlier than November. That's the bus depot, the Health and Social Care Academy, sustainable transport, and the digitalisation hub. I hope that makes sense.
Okay, thank you.
Any further questions? So Simon, the Health and Social Care Academy, what will be the output of that?
Well, the paper sets out the particular outcomes. So there'll be a greater percentage of people with higher qualifications within Warrington, and more people taking a portfolio career across health and social care, and that will be all ages. So people can have a portfolio career in the acute sector, community sector, social care, voluntary sector. But there are specific outcomes. It's just that my line's so poor I can't let you know, but they're in my paper.
Yeah, thank you very much. That's great. It's good to see we've got some cycling in there as well. I was pleased to see that.
We've got cycling, yeah, and we've got rowing and walking. So all those, so the different hubs, they'll be linked by the sustainable transport programme.
Brilliant. Okay, thanks very much. And it was good despite the poor quality line. Thanks, Simon. Which brings us to the Warrington Hospital update. Is that Lucy or is that Simon?
Thank you, Chair. I think we're doing a bit of a double act, if that's okay with you.
That's perfect, thank you.
A double act from myself and Lucy. So I think if it's okay with you, Chair, we propose to do our update in 2 parts. Firstly, just a brief situation report with regards to the COVID-19 situation in the hospital, which follows on from Tara's presentation. And then secondly, and I think more positively in terms of looking forward to the future, a proposal that we've got around breast screening and assessment services that we would like to present to you. So if I may, I'll start off with a brief situation report with respect to the hospital. It follows on nicely from the update that Tara's provided. So as of this evening, as we sit here discussing things, we have 59 COVID-19 positive inpatients at Warrington and Holton hospitals, all of which are at Warrington Hospital currently. You will recall that the peak of wave 3 was almost double the peak of wave 1, and that was 243 patients on the 19th of January. And since that peak of wave 3, there has been what can only be described as a frustratingly slow decline in numbers over the recent weeks. A slow but steady decline in recent numbers in recent weeks, but over the last couple of weeks we've been sort of maintaining around the 60 positive inpatient mark, reflecting, I think, that the position with regards to community prevalence. And if you look at Warrington and Holton hospitals compared to other acute trusts in Cheshire and Merseyside and the North West, you'll be able to understand why the hospital situation mirrors almost identically what's happening in the community. However, numbers are going in the right direction, albeit slowly. We're back in our normal intensive care unit footprint with 5 COVID positive inpatients, and if I was sitting here this time last month, it still would have been a very different situation. We were still very much escalated outside of the footprint, but fortunately now we're in our normal critical care footprint, which helps with our restoration and recovery in respect of theatres and anaesthetics particularly. Another marker of the acuity of patients we're looking after, and a positive marker in that respect, is that our current oxygen delivery demand, which is, I say, only approximately 16%, whereas if I were talking to you at the peak of wave 3, I think we would have been approaching 60, 70, 80% of our oxygen delivery capacity. So the fact that we're down to 16, I think, is a useful surrogate of the kind of acuity of patients we're looking after at this time, that generally on the recovery phase as opposed to all acute patients. Just some other markers I think are of interest. Our total staff absence is just over 7%, whereas I think in the worst case of the last 2 waves of peaks of wave 2 and 3, it's been over 10-11%. So that's reflective, of course, that our staff come from our local communities too. ED attendances have been quite significantly back to sort of normal levels, actually reflecting a normal sort of winter pattern over the last couple of weeks, and I think that's starting to have an impact too. And finally, with respect to our hospital hub, that in terms of vaccination, we've vaccinated, done over 23,000 vaccinations now, and have got a staff uptake of 90%, and in fact 41% of our staff have now had their second dose of vaccine, so we're well on to the second dosing regime now, but a 90% figure for staff is very good in the NHS, and I'm really pleased to say also that we've been called out as a beacon of good practice with regards to the way that we are engaging with our BAME community, and BAME staff particularly got very high uptakes in that group too. So at that point I'll pause, happy to take any questions on COVID-19 position before we go on to talk about our breast service.
Anyone have any questions for Simon? None at all? Okay. I think it's quite impressive vaccination totals there, Simon, and well done. And we thank you again for all the work you're doing. So,
thank you.
No questions at all for Simon? Okay, well, maybe we'll ask Lucy to do her bit as well now then.
Thank you. I'm just going to share my screen if that's okay. Can I just check that everyone can see that?
Yes, that's fine, thank you.
Great, thank you. Okay, so the purpose of this presentation is just to share with the committee our proposals to relocate some elements of our breast screening and assessment service from the Kendrick wing at Warrington Hospital to Holton Hospital. Importantly, though, retaining the current service that is provided at Bath Street. What I'll also aim to do is just describe the planned engagement and consultation processes, and really all I'm asking of the committee today is support in terms of progressing that engagement and then following that consultation post the election period. So just a little bit of context really in terms of breast screening and assessment. So breast screening is currently offered to all women aged 50 to 70 years every 3 years. And it's commissioned by, or elements of it at least are commissioned by NHS England specialised commissioning. And at Warrington and Holton Hospitals, we are the lead provider of that service, not just for Warrington and Holton, but also for Knowsley and St Helens. I don't think I need to describe why assessment is so important, or the screening element either. The final point though is probably quite helpful in terms of the assessment, including 3 elements, so mammography and ultrasound, clinical examination and image guided needle biopsy if required, and that's relevant in terms of the proposed service changes. So this slide just summarises the current service offer in terms of the number of people who are screened each year from Holton, Knowsley, St Helens and Warrington. So really significant numbers in terms of the volumes of people who are offered and attend screening. Really important to say that screening will continue to be provided in locations across Holton, Knowsley, St Helens and Warrington. So the only element of screening that we're proposing to move is the element that's delivered within Warrington Hospital, but the provision in Bath Street we planned to maintain and extend. So currently our breast service is delivered from the Kendrick wing. You can see a picture there of the very old building in Kendrick wing, which most of you are very familiar with. And there's just a little floor plan in terms of setting out what's currently provided. There's some pictures here. These actually make it look, I would argue, quite a bit nicer than it perhaps is in terms of the I guess the estate, and that's one of the key challenges that we have at the moment. So what we're trying to do strategically as a trust is to move all clinical services out of the Kendrick wing, just in terms of making sure that all of our clinical services are provided in kind of modern estate that is genuinely fit for purpose. And this is what it could look like in terms of, so the plan is to move some elements of breast screening and assessment into the Captain Sir Tom Moore building over at Holton, and there's just a picture of what that could look like in the future. So just to give a summary of the provision currently, so you can see on the left hand side there what the service is made up from an estates perspective currently within the Kendrick wing. I'm not going to kind of read all of those out, but you can also see the significant expansion that we would plan for in the Captain Sir Tom Moore building. I think that's a key point to note really. There's a recognition nationally from NHS England that there's a real challenge in terms of workforce for provision of breast services, and particularly that assessment element, and therefore there's kind of a national drive to co-locate some of those assessment services, because what that enables us to do is to deliver more capacity and more appointments with the same workforce, with the workforce being the kind of main constraint nationally. And so what this reflects on this slide is the increase in kind of physical estate provision to enable that to happen. So why relocate? The first thing is kind of really important to be able to provide screening and assessment clinics simultaneously. So really helpful from a patient's perspective if any abnormality is identified at the screening point, that they're able to rapidly access assessment services and ideally on the same site immediately post their screening appointment in one place. I've just mentioned the kind of local and national shortage of radiologists and mammographers, and so this really is a national drive in terms of co-locating some of those services at a local level to make sure that we can make best use of the staff that we do, and also importantly attract staff in the future to be able to best serve the population. So which kind of links to the operational efficiencies that we are able to deliver by bringing the two together, which allows us in turn to provide a service to more people more quickly. We did look across all of the sites in terms of Warrington, Halton and St Helens and Wiston in terms of and the population that we're serving, and therefore where would be the best place in terms of minimising travel for the vast majority of patients. And on that basis, Halton would be the preferred option from a geography perspective. So that's the provision of a service closer to home for the majority of the referring postcodes. I think that the fifth point on this slide really can't be underestimated in terms of the patient experience and accessibility. So the facilities in the Sir Captain Tom Moore building are considerably better from an estates perspective and a patient experience perspective than the current estate within the Kendrick wing at Warrington Hospital. And we have looked at whether there are any suitable locations at the Warrington Hospital site, and there aren't any at this stage. So in terms of people that would be impacted were we to progress this change in service provision, so predominantly the element that would be provided in Halton and no longer in Warrington is the symptomatic and assessment clinics. And we can see at the moment we've got 2,800 ladies per year attending that symptomatic service at Warrington and 1,100 the assessment clinic. It's worth highlighting that a proportion of those patients will be Halton patients who are currently travelling to Warrington. There's also an additional 300 patients attending an assessment clinic at St Helens at the moment. Those patients will be given a choice in terms of whether to attend at Halton or to continue to attend at St Helens, because we plan to continue to provide a clinic on the St Helens site. And there's just some points there in terms of accessibility from a Warrington perspective in terms of the free shuttle bus and also the public transport available from Warrington and St Helens. So the reason really for highlighting this today was to ask for support from the committee to progress some more formal engagement and consultation with the public. So in terms of summary of the changes that we'd like to engage and consult on, so there are 5 locations that women can choose to have their breast screening at the moment. So Bath Street, Halton Hospital, St Helens Hospital, Wiston Hospital and Warrington Hospital. There are, in addition to that, some mobile screening units as well. And the bit that we're planning to change would be to move the Warrington Hospital element of that to Halton, but to expand the Bath Street provision to make sure that any women who would like to access their screening appointment in Warrington are still absolutely able to do so. The second point then is if women need to have a follow-up service in terms of that symptomatic and assessment service, that they would then attend that service in Halton in the Sir Captain Tom Moore building. So that's just a summary of the kind of proposed changes that we would like to engage the public on. So the objectives of the engagement and consultation, to ensure that the population is made aware of the proposals and provided with a number of different platforms to be able to engage and participate and share their views with us, that they're able to make alternative recommendations and suggestions, and that anything that emerges from that engagement is taken into account in our plans going forwards, and any kind of mitigating actions are considered. And importantly, our kind of links to Tara's presentation earlier is making sure that our engagement also focuses on some of those harder to reach communities as well. The intention would then be to provide a report back to this committee on that initial engagement. So just to continue with that in terms of some of the engagement and consultation plans, in terms of some of the activities that would include around the development of FAQs and questionnaires, including provision in additional languages and easy read, and just a number of different ways in terms of enabling the public to engage on these proposals. And also there's some important points on this slide in terms of engaging with other key stakeholders, including MPs, for example. And then finally, just in terms of a timeline, so we'd like to commence our pre-consultation engagement from the 1st of April for a 6-week period. And then follow that kind of post the election period, progress to formal public consultation from the 28th of May, also for a 6-week period. Just a summary in terms of funding and risk and equality impact assessment in line with the papers that were provided to the committee. So we have secured £1.8 million funding from the Trust's capital programme for the proposed works, and the cost to run the consultation would also be funded by ourselves. And then we have a detailed risk log and have of course carried out an equality impact assessment. Happy to take any questions or comments.
Thank you very much, Lucy. Anyone have any comments or questions?
No.
Yeah, Paul, can I ask a question? Sorry.
Sarah.
Just on the consultation then and on the questionnaire, that's great. But just drilling that down a little bit further, how are you going to distribute that? I mean, media releases are great, but they can be, you know, potentially missed. It's just making sure that you get the widest scope possible. So what is the plan for that?
Thank you. So actually, we've just completed pre-engagement on another programme of work in Halton. If I just use that as an example in terms of some of the ways we'd make sure that we've been able to engage a lot of people. So absolutely the traditional ways that you've described in terms of media releases and social media, but what we've also done is kind of run some virtual sessions for members of the public, and also proactively engage with all of the existing patients of those services, so via existing clinics, for example. And it's really unfortunate, isn't it? Because ideally we'd also kind of make sure that we were in a public space and kind of engage with people face to face. That's obviously a bit challenging at the moment, but I think we had a really good response to the pre-engagement that we've just done. I know it's on a different programme, but we had over 300 responses, which was fantastic. So I think that's a good example of how we were able to kind of go out in lots of different ways. So yes, through the questionnaire, yes, through press releases, but social media was really helpful, and also some of those virtual sessions and our patients themselves. So, but welcome any other suggestions.
Okay, great, thank you.
I think consultation is a huge challenge at the best of times, but to have a lockdown and associated distancing, it's very difficult to meet people. So you said,
Simon, may I make a couple of comments too?
Yeah, sure. Yep.
I just under the purview of this committee in other areas, I just wanted to highlight how this fits in with the wider Warrington Halton Hospitals estate strategy for the future, so that it's all connected and not disconnected from each other. I think that's really important. I know this committee has been very interested on that, obviously too. So Lucy's talked about and given you a lovely photo of Kendrick Wing, which, if you will recall, was very badly damaged by fire in 2017, and we're still in the aftermath of all of that clearing up. But we were determined after that fire, with the disruption that occurred with regards to ophthalmology, that service then moved. But we were resolved then to move out clinical services out of what is a fantastic building. It's a lovely office space, but it really isn't fit for modern 21st century healthcare. And so this is part of us recalibrating, if you like, our services between Warrington and Holton that can make both Warrington Hospital and Holton Hospital propositions complementary to each other and not mutually exclusive, which was something that I think we talked about here on previous occasions. And I think there's also something worth talking about, the issue of what this service is all about. Largely, but not exclusively, this is a service about breast cancer, and it is the most common cancer in the United Kingdom, and therefore this really does move us into a system where you've got co-location of expertise, co-location of equipment, screening and assessment going alongside each other, so that you really do minimise, you speed up the pace of diagnosis, and you minimise the anxiety that is very, very problematic for so many, largely women, unfortunately. So I think it's a really important step. I think it's a positive step forward in terms of restoration and recovery on the back of COVID, in terms of the future, but in terms of providing a legacy for cancer services in this part of Cheshire and Merseyside, and dealing with some of the health inequalities that we talk about quite significantly.
Thank you very much, Simon. Has anyone any questions at all? Not at all? Okay. You were talking about the expansion of services at Bath Street for the assessments. Could you clarify that?
Thank you. Yes, so we currently provide screening for breast services at Bath Street, and the intention would be to expand that screening provision in order to make sure that anyone who wanted to access screening within Warrington is able to continue to do so, because at the moment there's an element of that screening provided also within the hospital setting. Okay.
Thanks very much. I think having a one-stop shop is always a very positive thing for whatever area of care that you're being investigated or treated for. So thanks, and thanks very much for sharing this with us. Very valuable. So hopefully the consultation will go well. So thanks to Simon and to Lucy. So that moves us on to item 7, which is the intermediate care services in Warrington, and we've got a report on this, I believe. And who's speaking to this?
Thanks, Chair. Shall I pick this item up? Hi, everyone. I'm Julie Haywood. I'm the project manager supporting the redesign of intermediate care services. So keeping in the spirit of consultation and engagement, the report that's been submitted to members follows up really from a briefing provided on the 12th of November last year to members, describing the intention to take some of the work that we were doing around the redesign of intermediate care out to public consultation. So in the report, you have some background description of the work that we've been underway with since June 2019, which has involved some work to redesign, enhance and improve intermediate care services, both bed-based and community. The paper defines intermediate care services for you if you aren't familiar with those services. So intermediate care services are a range of professionals working together to support people who might be in a crisis, either in the community or in hospital, and be able to be discharged earlier should support be available to assist them. The work around improving intermediate care services has been taking place over a period of time. The report, though, specifically highlights the work we've been doing around Padgate House, which has necessitated public consultation. So in the report, you'll see that we've ascertained that Padgate House is no longer fit for purpose. If you know the building as an estate, it's quite an old building. It's challenged by having rooms that can't facilitate en suite. The corridors are very narrow. It makes mobilising modern equipment quite difficult. There's insufficient space for parking and for visitors, and the availability of accessing space for the provision of therapy is quite constrained. So having taken stock of some options for the future of Padgate House, a number of future potential options were put to the public in a consultation. The report describes the approach we took to the consultation, which opened on the 7th of December and closed on the 28th of February. And having undertaken the consultation during COVID, you will see that we've endeavoured to do as much as we can with as much kind of breadth and variety of engagement, noting the constraints about face-to-face contact. So in the appendix of the report, you'll see the action plan that describes all the different mechanisms that we use to reach people, including the approach around letters and briefings and media, but as well the face-to-face work that we did manage to do in a COVID-safe way with existing patients in bed-based services, as well as some digital engagement sessions that we did with members of the public, as well as professionals and other stakeholders. To summarise the findings from the consultation, so you'll see in the report that we had 143 individual responders and 136 people attending groups. You'll see as well that there are some summarised outputs from those responses and people who contributed thoughts and opinions in relation to the options and the overarching intentions described in the consultation information. So in summary, the majority of respondents understood the need for us to improve intermediate care services as described in the consultation and engagement information. And that need for change was really premised on some of the requirements in the long-term plan and some of the aspirations in the long-term plan about more cohesive services, more focus on the multidisciplinary integrated service model, more focus on intercepting people before they reach the point of crisis and need in hospital, and a lot more focus on reablement and that kind of holistic approach to care. So the majority of respondents to the consultation fully understood the need for change. The majority of respondents also supported the intentions for the future. So in the consultation information, we supplied some explanation of what we think the future model looks like and how we'd move towards achieving the aspirations of the long-term plan, what that would mean for the way community services would look, and also what it meant for how we wanted to improve bed-based services. And the majority of respondents in the consultation process described understanding and supporting the future model. The majority of respondents thought the future model would deliver improvement. So they saw the future model of service as something that would be beneficial to the system and would improve the way that we can support and serve patients and people who need intermediate care services. And the majority of respondents also understood that in relation to bed-based services specifically and within that Padgate House, that there was a need for change, and there was recognition by the majority of respondents that the explanation of Padgate House as a building that's not fit for purpose was understood. For those people who then indicated a preference around their views of what should come after Padgate House, if you like, so of the three options that we described, which was their preferred, the majority of respondents supported option 2, which was provided to people as the opportunity to build a new facility on a new site identified at what was previously Busey Old School. In terms of people who didn't support or endorse some of the key messages in the consultation document, but the report details that disagreements were very few and small in number. And for most people, that was an expression of either experience at Padgate House or knowledge of Padgate House, and feeling that the environment of the building wasn't material to having had a good experience of patient care, and or being unconvinced about the need to re-provide Padgate House, either from a financial perspective or a geographical perspective, etc. So part of the mitigation that we want to put in place as we move forward is to just be clearer about the explanation of why Padgate House needs to be re-provided. So just to add to that explanation of why it can't just be modified or temporarily enhanced to meet the requirements of a 21st century service. So that's just to note that we will still address people's concerns in terms of people who didn't agree with the key kind of recommendations in the consultation. Separate to disagreements or agreements, there were a number of themes that were fed back through the consultation, which were of note, and which again we want to build into whatever comes next in terms of next steps for intermediate care. Just to summarise those as they're described in the report, they were primarily around things such as making sure that any future service maximises and leverages the use of technology, making sure that there's still really good integration and connectivity with primary care and with the hospital, ensuring that there's still the preservation of a really robust culture within services, so regardless of the building or the kind of environment that a service is provided in, that culture of quality and good patient care and experience is maintained. And so a number of themes, I think, came out regardless of agreement or disagreement that we want to make sure we build into next steps, and that we want to be able to loop back to and be able to give assurance to people that we took on board comments, even if they weren't expressing a particular view around an option or an ask in the consultation. So, subject to endorsement by this group that the approach we followed for the consultation was diligent and robust, we would like to move forward on accepting that the public have endorsed option 2 as the preferred option for the 3 that were submitted. One additional point to note that we would also like some support to move forward on was the emergence of an option, if you like, that we hadn't put to the public, but the public put back to us through a number of thematic pieces of feedback, both from the digital sessions where people came together as groups and from the individual responses in the survey. And that was around the theme of being absolutely assured that we had exhausted all potential existing options before moving forward on anything that involved any kind of new build. And the sense from the public, I think, from the feedback can be summarised that were we sure that the situation hadn't changed with the experience of COVID, were we convinced that land or buildings hadn't become available, that weren't available pre-COVID when the consultation was being designed, and did we need to kind of double check that before moving forward on option 2? So in the report, you'll see that there's some additional assurance provided where we have refreshed and revisited the assumptions about there being no other existing or suitable alternative site or building for the provision of the number of beds that we believe are required for the future. And you'll see that there's been some explanation around how that's been undertaken. And you'll see that the outputs from that desktop exercise are that the only potentially theoretically viable existing provision is the provision at Lily Cross. Lily Cross is currently in use for the provision of services not related specifically to intermediate care at this time. But in terms of a building as a desktop exercise, Lily Cross was the only building that came up as something that could theoretically be potentially considered for the future. So in addition to option 2, there's a need for us to just clearly understand the kind of future feasibility of Lily Cross, just to do diligence and to be responsive to the fact that that has been raised by the public, and it seems like something that we should be very clear about in terms of answering as a kind of issue that the public have raised. So to summarise, intermediate care services are being redesigned. That work has been ongoing since June 2019 and before. There's been substantial progress made in terms of designing a new approach for intermediate care and moving forward on all sorts of enhancements and improvements, particularly around the community model. We need to make some material changes to the bed-based element of provision, specifically related to the fact that Padgate House isn't fit for purpose for the future. We've consulted on some options for the future of Padgate House. There's one of the options that were provided to the public that has come out as more clearly endorsed. There's also an option that the public have suggested that wasn't provided to the public that needs further clarification and consideration. An equality impact assessment was completed at the outset of this project, and that will be refreshed and updated subject to the endorsement of the consultation outputs, and then that will be further refreshed and considered as any further feasibility work takes place on any of the future options. An outline business case has been produced and is currently moving through governance groups, just to kind of give an overview of what Busey Old School looks like as a kind of desktop exercise of the land and the potential scale and opportunity of the site. So again, subject to endorsement of the consultation process and the outputs, that business case will be further tested for feasibility, so that stakeholders and governing groups can understand in more detail what the potential opportunity is at Busey. I think that's all I wanted to raise at this stage. I'm really happy to take any questions. I think the summary of the ask to the group is endorse the approach and endorse the outputs that the approach has produced.
Thank you very much, Julie, and thanks for the comprehensive consultation and the report as well. Thank you. Does anyone have any questions for Julie on the redesign of intermediate care services?
Paul?
Yes.
Hi, it's Councillor Wheeler. Thanks, Julie, for that. Can I just ask, and if this is in the report, I do apologise because it is such a comprehensive report. Are there any implications for the services or the provision at Brampton Lodge?
So it's a steady state situation for the provision of all existing providers at the moment, which includes the 3 providers who currently make up our 58 beds around intermediate care. So that's Padgate House, Brampton Lodge and Woodley. In terms of making any changes to existing provision, I think that will happen after the process of feasibility testing on the next steps around these options. So if we think about the consultation as a process for identifying options for the future, they now need further investigation, and that needs to be done in detail. And so I would expect a steady state of current provision until decisions are made from that further feasibility work. We are continuing to engage with our stakeholders around the overarching redesign of intermediate care, including community and bed-based. And so that means, for example, I'm having conversations with staff at Padgate, Brampton and Woodley periodically, just to make sure they continue to feel engaged and included on the evolution of the future of intermediate care services.
Okay, that's really helpful. Thank you.
Thanks, Judith. Anyone else have any questions? No one at all? I think obviously you've done a very in-depth consultation, and one of the things about consultations is that sometimes they raise things you don't expect, and I think the Lily Cross option is something which I suppose does have some attractions, but the difficulty is if somebody's in intermediate care, then very often they probably have people that have difficulty travelling with the age and the like. So to get from Warrington or certain areas of Warrington to the Lily Cross facility in Widnes would actually place a lot of additional stress on somebody, a relative who was visiting. So I think obviously the facility has its benefits, but I think the placing of it isn't. And my thoughts would be that citing something in Busey would be a much more positive thing for Warrington residents. So, but thanks very much. And I'd like to ask the committee: are we going to endorse this this proposal? I think we're supposed to have a response at this stage. Do you want to come in, Judith?
Sorry, Paul, I was only going to say yes. If you
yeah, well, I think that's what Julie was hoping for. So thanks.
I'll say yes too.
I'm happy to second that as well.
Yeah.
I think it's,
and an incredible amount of work. I think a big thank you. An incredible amount of work that's gone into this. Really impressive.
Yeah, and I'll second that as well. Thank you very much, Julie. Yeah, I think you're taking this report as well to the Health and Wellbeing Board later this week. Yeah, so, but thanks again on behalf of the committee for all the work you've done. That's great.
Thank you. Thanks so much, everyone.
Thank you. Which brings us to item number 8, which is an update on the North West Boroughs acquisition of North West Boroughs acquisition by Merseycare. And who's speaking to this? I don't have a list.
It's myself. It's Lorna Pink from North West Boroughs.
Okay.
I'm on the telephone, so hopefully you can hear me okay.
We can hear you fine. Thanks. You go ahead.
Okay. Thank you. Adam was going to help by sharing the presentation. So is that visible yet?
Yes, it is. Thank you.
Okay. So just looking at the first slide, which says transaction update. So obviously I'm Lorna Pink. I'm the Assistant Clinical Director for Warrington, and that'll be for Warrington and Halton over the next month or so. And it's just to give you an update on the acquisition. So we're going to go on to slide 2, which is headed transaction update. So just going back to January, The key things that happened in January is that the financial separation plan was agreed, and this is that Wigan services, as you'll know, Wigan and Bolton are going to Greater Manchester Mental Health Trust, and then the Mid Mersey services, which is Cheshire and Mersey, going to Mersey Care Foundation Trust. And that was the financial arrangements that were agreed in January. And they were discussed at the Cheshire and Mersey Commissioner Stakeholder Forum. They met in January and approved, and then there was an agreement at the transaction board in January for those transfers to take place. Dates being Wigan and Bolton services going on the 1st of April, and then the Cheshire and Merseyside services and staff going to Mersey Care on the 1st of June. All the North West Borough staff received letters explaining where they would be transferred to. So in February, we went into formal staff consultation, and this is basically saying this is where you're going to be transferred to, but an opportunity to ask questions. That was really well supported by both Mersey Care and North West Boroughs, with question and answer sessions, the chief executive coming and speaking, opportunities to really find out what that would impact that would have on staff in particular. So Mersey Care Foundation Trust Board of Directors approved the business case, and they submitted that to NHS England and NHSI, and then Greater Manchester Mental Health Trust did the same as well. Both Mersey Care and Greater Manchester Mental Health Trust commenced registration of the services with the CQC, and there was another transaction board at the end of last week. So just to say that it has felt very much like a joint approach, and that there's 8 work streams and they're jointly co-chaired between Mersey Care and North West Boroughs in terms of their work streams, and the transaction programme group meets fortnightly, and then the sort of next steps will go on to, we go on to the next slide, which says next steps March to May, just to go on to how NHS Improvement are monitoring and continuing to audit this process, obviously to keep it a safe process. So they have just started meetings and interviews with both Mersey Care staff and also external stakeholders and North West Borough staff. So I think I was one of the first groups of leadership people to meet with them this week. So that process is about saying things like, you know, what impact and advantages do we think this will have to service users and patients? What impact do you think this will have on staff? Where's the advantages? How will it support things like the long-term plan? So very much kind of getting views. And what they'll do with that is they'll summarise all of that information and take that to the board with Mersey Care. And at that point, they make a decision about a risk score for the acquisition. And obviously that will be RAG rated. Based on that information, Mersey Care and North West Boroughs will look at that, and obviously unless it was there's some really unexpected things that came out, then we would expect them to confirm that the acquisition would proceed, and that meeting is on the 29th of March. Both councils of governors will vote to approve the acquisition, and both trusts sign on behalf of both boards make the joint application to NHS Improvement. Then the next step then is that NHS Improvement issued the grant of acquisition and dissolved North West Boroughs Health Trust. So next one is stakeholder engagement. So I've talked a lot already about the staff engagement that's happened. So in terms of making sure our stakeholders are aware of what's happening, Mersey Care's programme director and clinical director, so Chris Lyons and Ray Walker, have both attended the Warrington Mental Health Partnership Board along with North West Boroughs reps who go to that board anyway, and that was on the 10th of March. They're due to go to the Halton Suicide Prevention Partnership, that was today, and then they've also been invited to St Helens Learning Disability and Autism Board and St Helens Mental Health and Wellbeing Board in June and July. I know that's not as relevant to Warrington, but just let you know they are looking at this across the whole of the Mid-Mersey. Mersey Care are committed to meet with local stakeholders groups to discuss the post-acquisition service development intentions, and there's a direct contact on the slide of Melissa McGowan, and she said please contact her directly if anybody has any questions about the post-acquisition aspects of the service changes. So go on to the next slide. So obviously our service users are very much at the front of our minds. Patient care will not be affected, so the services that provide the services currently, if you go to physiotherapy with your physiotherapist, that will continue after June. People will continue to see the same healthcare professionals and they'll continue to receive the same care in the same location. What they will see is like the logo changing on the letter. So after the 1st of June, it will say Mersey Care Foundation Trust instead. So with that in mind, we want to make sure that patients and service users are reassured this won't change their care, and we're keeping those communications low key and very much focusing on reassurance. The plans are in place to communicate with and reassure service users and their families and carers about the transfer of care. And that'll be done through various channels. Obviously, we're focused on the Wigan aspect up to now because that's what's happening in the next week or two. But we have started to have those conversations with our service users, patients and families as healthcare workers when they're coming to appointments. And we'll also be using putting information into patients' letters. There's an animation going onto our website. There's social media will be used, Twitter, etc. And be posted in the sites that people come to. But we're very much, you know, individual professionals will be talking to their own service users and patients and explaining what won't change and actually what they might see that will be different, which will be the letters and our name badges. So talking obviously also with people about the benefits of care being provided by a larger NHS organisation. So there's obviously that critical mass aspect in terms of expertise that you get by sharing, that kind of standardisation that you get by sharing, and hopefully all that levelling up that we can do as a bigger organisation. And obviously we'll be looking, as always we do in Warrington, towards our Health Watch groups who always support us with public information and gathering feedback and information from our service users too, to try and get the message out to as many people as possible. And that's it from me, unless you've got any questions.
Thanks, Lorna. Anyone have any questions? None at all? I'll ask one. Lorna, you're saying that the services will remain unchanged, but what are going to be the positive benefits for the residents of Warrington and the service users within Warrington? That I know you're talking about they've got the larger expertise, but does that not already exist?
Well, obviously we're going to go from being a 4,000 employee organisation to I think it's about a 10,000 employee organisation. So just that strength of those clinical and professional networks will be extended. So we have very few services that look after forensic sort of needs in Warrington commissioned at the moment. But obviously Mersey Care are a national leader on forensic services and forensic care. So just to have that enhanced clinical expertise within your own organisation, we have clinical networks, and just be able to draw on that, I think, will be a real advantage.
And the services such as, for example, adult ADHD, would that then potentially be something that would then be offered within Warrington rather than being outside the town?
I think that's probably a question for the CCG, because I understand the ADHD service for Warrington is commissioned through a different provider than North West Boroughs.
Yeah. Okay. Right. Well, maybe we'll come back to that another time. But anyone have any further questions for Lorna? Not at all? Okay. Thanks again.
Thank you. Thank you very much.
The acquisition. Thank you. Okay. Which brings us to item number 9, which is the partner update. And first on our list is Bridgewater. So I'm sorry, I can't see who's here. So
hi, it's Sarah Quinn, Chief Operating Officer from Bridgewater.
Hi, Sarah. Thanks.
Hi. Just to give you really a brief update. So we've continued to maintain all our community services throughout the third wave of COVID-19, and we've been able to do that with minimal redeployment of our staff. And we've maintained a significant amount of activity, both face-to-face, via video consultations and by phone. We've also provided extensive support for hospital discharge, and we redeployed some of our therapy staff into transitional beds at Lily Cross, and we've supported around the discharge to assess and intermediate care at home to get patients back to their own homes. We've maintained all our staff in our children's services, which has been increasingly important. We've seen considerable pressure on these services, particularly in recent weeks, and we've seen families requiring more extensive support, and some of our visits times have doubled in length, and we've seen a significant increase in perinatal mental health issues. We have all our staff are now receiving their second dose of their vaccinations, and we, alongside Warrington Hospital, have a very high uptake. I think ours is almost 90%, and we've got large cohorts of staff using lateral flow testing, and we've got all our staff this week who are going into care homes doing the twice weekly testing. We've taken the opportunity as a trust to review all our governance arrangements around our command and control structure, and also looking at our quality impact assessment process. We've got a number of services who have been in and out of business continuity now for a period of 12 months. And so we've taken some extensive reviews in relation to the quality of those services and the risks within those. And we're looking at where staff have been redeployed and where we've had to pause activity or to deliver it in a slightly different way. We're also developing extensive recovery plans, and we're trying to really return to business as usual and to step up our services activity and our reporting from a corporate perspective. I think doing that in the backdrop of supporting discharge from hospital, maintaining and working alongside our PCN colleagues and developing those relationships, whilst also supporting our staff health and wellbeing. I think it's fair to say that our staff have undergone an extensive period of change and tested their resilience over the last 12 months. We've seen a considerable decrease, so really back from the January meeting, in our staff sickness, and the figures are comparable with the hospital, and we've seen a considerable drop in relation to the COVID related sickness. So I think from our perspective, we're maintaining our services and just looking at how we deliver those as part of the business as usual, and managing COVID as part of our routine business.
Thank you very much, Sarah, for that update. Does anyone have any questions for Sarah? No one at all?
Paul,
okay, Judith. Yes, Judith, you want to go ahead?
Yeah, I just wanted to ask really what, I suppose it's pretty obvious what the challenges have been. I think what have been sort of the biggest surprises and perhaps the unexpecteds that you've faced during the past year?
I think it's all the unknowns and just being prepared, isn't it? And having to adapt services quite rapidly and to adapt for staff in terms of the methods of service delivery, and then also to cope with the challenges of your own workforce and supporting them. I suppose with periods of lockdown and schools not in place, it's been difficult to balance having sufficient staff and to deliver care in a different way. And so I think staff are really tired of all the changes that they've been through, and the test on the resilience, and then also supporting, making sure our patients have access to all our services, because we might have changed the way in which we deliver the service, and continually listening to that feedback really and adapting service provision in relation to that. I think as well, you feel it's a difficult challenge from a clinician perspective when you know you've got a long waiting list for a service which you're trying to deliver. And I think it's that balance of keeping everybody on those waiting lists safe and making sure we're bringing patients in. It's that continual reassessment and clinical prioritisation, and encouraging patients to be in contact with services so they access them when they need them.
Okay, yeah, thank you.
Thank you. Anyone else have any questions? Could I ask a general question about the service provision then, Sarah? How is it that sometimes you would be able to lose a service that, or lose a tender for a service that you previously or currently would provide?
I think in terms of that, sometimes we've made decisions not to rebid for services that we might have provided, or obviously other people make bids for services, and I suppose that's the way in which the process is at the minute. I suppose some of the steps in the white paper set out a different agenda and more focus around place instead of the competitive tendering process.
And if something would be seen to be, I suppose, fundamental to a community services such as out of hours, is that still go down the tendering route?
That particular provision has gone down the tendering route. I think as an organisation, we it was the services were tendered over a large footprint across Cheshire and Merseyside, and I think that we are very focused around the provision of care in particular places, and so that footprint of services, we weren't able to commit to providing the quality of services that we would have liked to over such a large footprint, because our main business is not around that particular provision of services, and we are, our staffing is more around nursing care as opposed to medical cover. And I think over a number of years we've struggled to recruit medical staff into that service, so to take that over a bigger footprint would have been quite challenging from that perspective.
And the service you're referring to is
the GP out of hours, the one that you picked up?
Right. Okay, right, thank you. And how's things with staff support? What are you doing with staff support during COVID?
We have an extensive health and wellbeing offer for all of our staff. So we've introduced a number of different provisions in relation to that, and staff are supported. We have regular communications in the trust of all of the health and wellbeing offer. We have regular support visits right down from execs all the way through to clinical managers and team leaders. So we have that portfolio offer to support staff to keep them in work during COVID. And I think that has been challenges, and we've had to respond and amend our offer and the services that staff need at various different points of the pandemic over the last 12 months.
Okay, and anyone have any further questions? Then I shall ask a last one. Are there any other services that may be going out to tender that you would be seen to be releasing in a similar way to what's happened within Bath Street?
Not that I'm aware of, no.
Okay, thanks very much, Sarah. Thank you. Okay, which brings us to Lydia and Health Watch Warrington. Hi, Lydia.
Thank you. Yeah, thank you. Good evening, Chair. I've just got a summary report, a 5-month summary report, which we will be sharing at the Health and Wellbeing Board on Thursday. So I thought I'd bring this here, and I'll just highlight as we go through the pages, just some points, and then if I can send this out as well for everybody if they'd like a copy.
Thank you.
Okay, so starting from sort of October to February. Community Voice, we've carried out 107 virtual outreach sessions, and we've engaged with 774 people on those. We've had just over 17,000 page views on our website, so that's an increase. And we've been working with several groups that's listed there. I'm not too sure if you can see that actually on the slide there, but so Cancer Survivors Group, Arthritis UK, Wired Carers, etc. There's quite a few there. We've also had a lot of calls around dentistry. I think there were 62 calls, and we had about 30 emails from the public asking sort of issues around not being able to be seen, not having appointments, cancelled appointments, and also taking off registers as well. We have highlighted this to the head of primary care, and we meet with him once a month now, and we also meet with Cheshire and Halton as well, so we escalate any dentistry issues there. And we've put on there's an infographics on our website as well there, if anybody needs any more details, and there's a Health Watch England report as well around dentistry. We've got project updates around mental health barriers with children and young people services, and following on from our mental health report, young people's mental health report, we met with North West Boroughs and also CCG, And the good news is we will be working on a 12-month project for young people, and we will be working with different groups within schools as well, and certain focus groups around young people and how the effects of COVID have been on them, and working with Steve Tatham as well from CCG. We're working with hard to reach groups as well to increase the uptake of the awareness of the COVID vaccine. And again, we're working with Cheshire and also Halton collectively, looking at sort of certain communities like the boating community, asylum seekers and women's refuge, which are some of the groups that we'll be working with. We've just finished our PCN alignment work with the 5 PCNs, and we've been working within care homes to inform residents and families around the GP alignment. We've been working with 3 common cancers feedback, and we've also increased our recruitment for our people panel. I think that's on the next page, Adam. Yeah. And we're also recruiting for the virtual voices. So that's obviously people who will be able to answer surveys virtually. I think we've got 200 people now on that, which is quite good. We're working with our partners. So, for example, they will submit questions into that, and we can send surveys out to people. We've worked on carers strain and priorities, e-consult, dentistry and vaccinations as well. We are working with digitally excluded as well. And we are working with Warrington Youth Club with our Youth Voice. And this is a panel of 12 young people. And they've basically created their own videos, their own avatars and surveys. And I think they've contacted up to now about 100 young people. And they will basically have their say around sort of health and social care services for Warrington. And eventually, when we can actually go back to our interim views physically, we will train some of the young people into some of the areas around interim view, and they'll be able to input their opinions on that. We're working with the Rapid Response Service as well, and basically that's to ensure there's an independent view for patient feedback. That's with the CCG. And we're currently advertising for the public for Health Watch priorities for April for this year for our new priorities. We've spoken to all our partners, and it will go to a public vote as well to see what they would like us to work on. And I think at the moment it's looking possibly around sort of COVID, children, young people's mental health, and the new town centre bid as well. Got a list of the main public intelligence themes there, and that can include sort of e-consult, children, young people, COVID vaccines and dentistry, as I mentioned before. And I think the next couple of pages are just some of our videos that are online, which we've produced. We've had good feedback from the public. And then the next couple of pages are just basically all the stakeholder groups that we sit on, all the meetings that we input in. And I'd just possibly like to finish. There's a list as well of our advisory board meetings as well, future board meetings, which are open to the public. So if anybody would like to attend, please visit our website. Thank you. I think that's all I've got to say.
Thank you very much, Lydia. Has anyone any questions for Lydia at all? So, no one? Lydia, could I ask just about the dental surgery and dental services? You're saying the impact upon dental health and access to dentistry. Is there any issues regarding dentists moving away from NHS dentistry to become private? And is that having any impact that you're aware of?
That's a very good question. Not that I'm aware of, not what we've received in Warrington. It was mainly around the issues around access to appointments. we've had some feedback where people have been advised to go private if they couldn't get access to NHS. I think we have had a couple of emails regarding that, but mainly it was people who've said that they've received letters around asking to be taken off the register, and they hadn't used the surgery for so long.
No, I think the issue was that I think some of the dentists are struggling because of COVID, and they've made the decision to become private, and then the NHS patients are being invited to become private patients of the same practice. And I was just wondering if there would be if there's a pattern of that that's developing, or if it's just a couple of the dentist surgeries that I'm aware of.
Right. Well, I'd like to know a little bit more about that, actually. I wasn't aware of that, to be honest.
Okay. Maybe I'll come back to you then with that. Thanks.
Please, because I can escalate that across to Tom Knight when I meet with him.
That's great. Thanks very much, Lydia.
Thank
Anyone
you.
have any further questions for Lydia? It'd be great if you could circulate the report for us.
Yes, Adam's got that. Yeah.
Okay. Thank you very much.
Thank you.
Thanks, Lydia. So that brings us to North West Boroughs, but we've already done that, unless there's anything further to add.
No, thank you.
Okay, thanks. And Tara, anything further to add for the public health? I think Tara might still be on the phone to Steve. So that brings us to Warrington Borough Council, and who's here on behalf of Warrington Council? I do know this.
I think you've got me and Kath.
Kath?
Got Amanda Amesbury and Kath
Oh,
Jones.
that's right.
So.
Okay, and another double act, so that's great. Anything to add here?
Do you want to start with children's and then go to adults, so we follow the life pathway?
Yeah, that would be great. Thank you.
Okay, so we've seen, as I said before, we've seen an increase in referrals from schools more recently, safeguarding referrals for children. Prior to that, we had a very steady state compared to previous years, which was out of kilt with other areas, but that was our experience locally, which we were celebrating, thinking that wouldn't mean we'd get a spike when schools went back, but clearly that the last 2 weeks, and it might just be a moment in time, that hasn't proven to be the case. We've not seen a significant increase in referrals from health as part of that. We did see an increase in our numbers in children in care, but they've come down again now and are reducing once more. The reason I mention that here is because we did have an issue with getting children care's health assessments completed at the start of the pandemic, but that's levelled itself out again. But going back to dentistry, we continue to struggle to get dentists to see children, and our end of year figure for that normally ends up about, I'm normally sucking sherbet lemons if it's not above 80–85%, but we are stuck stubbornly at 12% on getting our children to see dentists this year, and that's a national issue, not just a Warrington issue, because dentists shut down for so long, didn't they? But the GPs carried on with the health assessments or picked them up again much quicker. Sticking with medicals, our foster carers and adopters medicals have continued throughout the pandemic, although we did move to them being done virtually, which was in line with the flexibilities in the regulations. We've just commissioned and will launch soon alongside our CCG colleagues an organisation called Pure Insights, about to look at the SLA for that this week. They will be providing support to our care leavers around emotional health and wellbeing needs, and that will be inclusive of a mentoring scheme. And Andy is down to speak after me, I think, but we're very grateful to the support of Pauline Owens in helping us to get that over the line to where it is now and securing funding jointly with us. We're also working on a bid alongside CCG colleagues to NHS England to develop a complex needs service in Warrington if we get money as part of the NHS's long-term plan. We'll come back to that in due course. If we get money from that bid, it'll be quite transformational in terms of our approach to children in that grey area of mental health complex needs that we spoke about earlier on this evening. We where am I up to? We launch our No Wrong Door in Warrington. Our No Wrong Door is going to be called the Lighthouse. Our children have named it now. So the Lighthouse launches on the 1st of April. That's going to be an integrated service, including health wraparounds directly to the child from one place rather than going out to different services, including speech and language, which is absolutely critical. We've learnt more and more about that over recent years, haven't we? And CAMS as well, working alongside us. And finally, we've been working closely with CAMS to further develop and embed our systemic practice model into social work and trauma-informed practices into schools across the wider partnership. That's kind of the interface of my bit of the world with health at the moment.
Thank you very much, Amanda. Does anyone have any questions for Amanda? Okay, you got off lightly there, I think. Thank you very much, Amanda. And Kath, you can do adults.
Okay. I think what I would say is that overall capacity is extremely stretched across adult social care. Probably in line with many other areas, we've experienced much higher safeguarding levels of inquiries and referrals than pre-COVID, and our unallocated work continues to rise. I think some of that is a result of the support that we've transferred directly over to the hospital in terms of ensuring that we keep the flow of discharges out of hospital, and that's had an impact, if you like, at the back office. An area of concern remains the funding arrangements as a result of supporting discharges out of hospital through the Discharge to Assess funding stream. It has been announced that that will be extended beyond March the 31st, which is where people get up to 6 weeks free funding, but it's not clear yet how that will be allocated. And this also, apart from a potential financial risk, it's also a significantly higher work requirement on the community teams to ensure that those people are picked up, assessed, and as much as possible supported to return home. It's been really positive around Discharge to Assess in that we've started a pilot which has been really successful in terms of reaching into the hospital and physically going into the wards, taking people home, settling them at home and wrapping the services around them. And that initiative will continue to develop because the focus of our efforts, we want to be much more on supporting people to be discharged directly into the community rather than into some temporary bed-based care, which we do need to do of necessity at the moment. You've heard about the intermediate care developments, which are ongoing and really encouraging, that we've managed to continue despite COVID. And we have also established a Living Well work stream, which has now met twice and is supporting the development of community-led support initiatives, which are about trying to ensure that we keep care as closely linked to communities and places as possible. And we are working with the National Development Team for Inclusion to help us on that journey for the next 18 months. So that's also encouraging. Services generally remain steady. We have sufficient capacity in our domiciliary services, and the situation has stabilised with our care home settings. However, the vacancy rates do remain high, and there are some concerns around sustainability in that sector long term as a result of the devastating impact of COVID. That's probably the key issues for now.
Thanks very much, Kath. Anyone have any questions at all for Kath?
Paul?
Yep.
Paul, could I just
identify yourself? I'm sorry, I can't.
Sorry, it's Judith. Sorry, Councillor Wheeler. Hi, Kathy.
Hi.
Kath, sorry. I just wondered, could you provide a little bit more information about this wraparound service of actually going into hospitals, and which sounds like a fantastic idea. I just wondered who was involved, and actually from the hospital point of view and from when people get to their own homes.
Yes, so this is a system-wide development. So we're working particularly closely with our partners Bridgewater, but also linking in very closely to the hospital. So the ambition of this service is that rather than spending time assessing people on the ward when they're medically fit, and as we know, that's not the best place for people to be if they're well enough to go home. The aim of this service is, as soon as someone is medically fit, within 2 hours of them being medically fit, we are able to support individuals to either go to another destination where other than an acute hospital, where they will receive a wraparound assessment, or if the services are available, to be able to come into the hospital, take them home, establish them at home, and wrap around those services that will enable them to recover in their own home, which is often the best place for people to make that rapid recovery. So it's about making sure that we don't focus assessment whilst they're inpatients, but actually try and ensure that we move people quickly and do those assessments off-site, where we can get a better view of someone's functioning, and also promote their independence more, because we often give them more services than they need, because it's hard to assess people in the environment of a hospital. Whereas if we can get people home, we can ensure that the services are more targeted at what they actually need. Does that make sense? So we have therapists, social workers, support workers, all engaged in that process in a multidisciplinary way to support people so they get the services they need when they come home.
Yes, no, thank you. How are you going to measure that in terms of how successful this approach is? In terms of, I suppose, readmission rates or level of functioning? I don't know.
Yes, we are already measuring in that way, but there are also discharge to assess is a national requirement and initiative, which is also coming, especially as we're coming out of COVID, with increased focus around national indicators, which will look at exactly that kind of indicator. How many people have been readmitted? Have people managed to stay home for 90 days or longer? Have they retained their independence? How quickly have we managed to get them home? Has it been within the 2-hour target? It's so there's a series of national indicators which will be set, as well as what we will want to be collecting locally, which will probably be more of a qualitative nature about people's experience and how person-centred that care has been.
Yeah, thank you. Yeah, thank you.
It's really encouraging to see that people are being discharged from hospital as soon as they're fit to be discharged, and they've got a multi-professional team around to support them, I suppose, to optimise their recovery. So what's the issue with the funding? Is that definitely going to be continued, and is it going to continue for a short period of time or long term?
Well, until in fact, I think it was only till a week ago, we didn't know that the funding for discharge to assess was going to be beyond the end of March 31st. And then there was an announcement last week for further funding, and we're awaiting the details and guidance on that in terms of how that's going to be allocated within each system. It's made a huge difference because we have been able to move people off site so that they're not exposed to illness and COVID longer than they need to be, so that we can assess them in an alternative location. So it's good news that the funding has temporarily been extended, and as with many other of the funding pots from the government, we will wait to see whether that continues on a more permanent basis. Our aspiration, however, anyway, as a system, is that we use the funding that we do have available to try and develop that model, and we've been on that journey for 18 months to develop our community services so that we can get to that point of moving people out of hospital as soon as they are well, so that we can assess their needs and support them at home. But it will take, I don't know what to say really. There's a level of complexity around being able to shift how we fund services from bed-based care to community care to make that possible. But we're working together closely as a system to plan for that as much as possible.
I think it would be much easier for everybody if the issue of social care funding was sorted out as promised, or promised on a number of occasions.
Yeah.
But that's a conversation for another time, perhaps. But yeah, promises. Hey, anyone have any further questions for Kath? Okay, thanks very much. So thank you to Kath and to Amanda for your input. That's great and very valuable. Thanks very much. So it brings us to Warrington CCG, and is that you, Andy?
It is me, thank you, Chair. So a bit of an update. I suppose we've seen some good examples of partnership working across the system this evening in terms of the papers that have been received. It's worthwhile highlighting some of the recent press as well around the out-of-hours service. I think you alluded to it with the question to Sarah. There was an article in the Warrington Guardian about the GP out-of-hours, and it's probably worthwhile clarifying what that is about and helping the committee understand the provenance of that story and where things have come from. So you'll recall way back in 2016, we started a move of GP out of hours to Bath Street, which was mobilised over the next couple of years. In 2018, we undertook a post-mobilisation review, which gave us feedback about how that service had been received and what impact it was having for patients, and received good feedback about the quality, site, location and hours of operation of the service. Over 2019, there was a national policy direction that all GP out of hours had to be under one contract per region and wasn't amenable to local contracting anymore. So we had to start to think about how that would work and work in partnership with other areas across Cheshire and Merseyside. And at that point, we had a number of conversations through Health and Wellbeing Board and other fora, culminating in November 2019 in a conversation at the Health and Wellbeing Board about the out-of-hours direction as part of integrated urgent care. The CSU, who are our commissioning support unit, undertook a procurement process with partners across the region, which actually returned its opinion in March 2020, which was in the midst of COVID. And as Sarah said, Bridgewater weren't able to pick up the larger footprint because they didn't have a predominantly medical workforce. And the recommendation was for that contract to be mobilised by PC24 across the region. This obviously was a change for us, but we had managed to specify that the service would remain as was based on that consultation. So the hours of operation of the site were to remain the same and the service offered was to remain the same. And we undertook an EIA and a QIA in January to validate that that was the case. And there were the concerns that came back from the stakeholder groups there were about changing location, and there was no change in location proposed as part of the contract mobilisation. The contract was due to mobilise in the middle of last year in June, July, but obviously given the pressures that were everybody was under, it wasn't felt right to mobilise at that point, so that the mobilisation was deferred through to this year. I think the article is based on some of the staff consultation. Under the change in the provider staff are entitled to 2p across. And as there's no ambition to change the hours or type of service, there's an expectation that all staff would be entitled to 2p. I think the wrinkle in there is that there are a small number of staff that Bridgewater employ who are on bank contracts, so they might not be recognised as having substantive hours, and I think that's the conversation that the providers are having. And usually from a commissioning perspective, we're not involved in that conversation. That's something to work through with HR departments in the providers, and I'm sure it will be worked through. However, I think some of that has surfaced in the newspaper article that was reported, but we wouldn't recognise that as a commissioner as being something that will be an appropriate outcome for the change in the contracts, given that the service is entirely the same as it goes over from provider to provider. So I suppose if that's helpful context, Chair, I'll leave that bit there, but we can come back to that if there's any questions. Just an update on vaccines. Really good success story. Again, another fantastic partnership offer in terms of the multiplicity of delivery. So PCNs have been delivering the community vaccination sites from the stadium and Orford Park. Hospital Trust has been delivering vaccines predominantly to care workers and others from the hospital sites, and we've also had a pharmacy site in the Imam Centre and a recently opened one in the Village Hotel, which is helping us get through those vaccines. There's about 113,000 people that are in the at-risk cohorts 1 to 9, and currently we are, as of the 18th, 83,000 people have been vaccinated, so substantially through that cohort, 73%. And for the most at risk in cohorts 1 to 4, we've got through 95% of that, so that's really good progress. And we're seeing that in terms of across the region and locally, with a reduction in severe illness and hospitalisations, plateaued a bit locally, as Simon indicated earlier. So in total, over 57% of the adult population in Warrington have had at least their first dose, which is really good. Next phase is cohorts 10 to 12, and they'll be announced, I think, towards the beginning of next month. And those are 3 bands, 40 to 49, 30 to 39, and 18 to 29. And those will be worked through in order down from 12 to 10. 10 to 12 to get through the rest of the adult population, hopefully by the end of July. So on the 11th of March, NHS England invited the practices to participate in that through the PCNs. That hadn't really been an offer before, and they were asked to respond by the 19th of March, so not given much time to prepare for that. We've got one site that will continue to deliver through those cohorts 10 to 12 that's run by the PCNs, and the other sites, the pharmacy sites and the hospital, will pick up the rest of the patients for the rest of the borough across there. So we've got plans in place that will continue that programme, and we do have one of the PCNs that will carry on delivery there. The Imam Pharmacy is run at Busey, and Pharmacy to You are running the service in the Village Hotel. So we've got continuation of delivery at Orford Park, and there'll be a plan to see when we, through the second doses for cohorts 1 to 9, what we need to do with Halliwell Jones. But there was pressure on that site due to the season potentially starting up again in May. So the timing works quite well for that. And that was it, Chair, from me.
Thank you very much. Has anyone any questions for Andy? No one at all.
Hi, Paul. Sorry, I have. I've got a crying baby in the background. Sorry,
okay.
Sarah.
Oh no.
Sorry about the baby.
Don't apologise.
It's just about. Sorry, I'm going to close the door. It's just about access to GP appointments. I noticed there was a report, a Health Watch England report on access to GP appointments during the pandemic, and what impact potentially the digitalisation of services might be having on particular tranches of people accessing those appointments. So I just wondered locally whether there was going to be a focus just to see whether that had been a problem, or whether going forward it's going to continue to be a problem. I mean, have you noticed any trends in terms of people accessing GP appointments or not being able to? Does that make sense?
We haven't had problems with contacts. The fairly early on we activated the online service for GP triage so that people could put the concerns in through the websites, which obviously gets most of the web enabled population. And we also had exception processes for people who needed to use the telephone so that they could get their queries answered by the telephone. So we did get quite good contact. I think the shift was then if people needed a face-to-face assessment, how was that conducted? So a lot of the triage resulted in care and treatment advice based on a telephone consultation or the written consultation or a video consultation. So it was more the access to face-to-face activity which was more constrained initially, and we did see that was having an impact. We had some face-to-face sites put on that were COVID secure, so that if people had symptoms which may have been COVID and needed that safe site to be seen, that they could be seen there. And what we're starting to, we have maintained those throughout, and we're starting to shift back to more what we call business as usual delivery. So still the same triage, same COVID secure offering practices, and getting people through. And what we've done is monitored people's access and activities and monitored the referral patterns from practices. So referrals for 2-week waits and for other services as well. There is a reduction in referrals on for routine. The cancer 2-week waits has come back up after initial dip, but we didn't see a subsequent rise. So we've gone back to our normal levels, but we haven't caught up for whatever that dip. So that is of concern. And I suppose the other areas that we've got concern of are particularly vulnerable people who might have long-term conditions and diabetes. So there's people who haven't had their usual annual foot checks, and that's quite an important part of diabetes care. And that was one of the things that was quite heavily restricted. So that is something that we've got some focused work planned on about catching up on that. And the other areas that we've actually done okay with, but we've got to focus on cancer screening programs. The vaccines and immunisations for general diseases locally, we did really well. We didn't really lose any ground on that, so we've been able to maintain. In other areas that wasn't quite the same, but we were able to keep those programs going. So there's a good breadth of information that we've got. I think the main hits we took were on cancer referrals, and we've still got some reductions in normal referrals on to hospital, which we need to work through. And there is work ongoing about what are those cohorts, are there any particular hotspots and any particular conditions that we need to focus on during the next phase of recovery.
Okay, thank you.
Could I just take that a little bit further, Ali? I'm aware that a number of people who may not be particularly web enabled are still ringing up GP practices, and then there's complaints happening because they're 15th in a queue and then they get cut off after 45 minutes or something like that. So I heard about this, and I did a secret shopper,
a mystery shopper,
and I rang a GP practice, but the message that was given was just hold the line. There was no direction on the loop of the information being given that they should consider using eConsult. And I just wondered whether or not there could be some benefit of changing the messages within a GP practice. So then if you want to hold the line, you can do so, but you might get faster service if you book onto eConsult and make people aware of that, because the GP voice message or holding message didn't actually address it.
So it's a good point, Councillor Warburton. We have the practices all have their own telephony systems. It's not a unified telephony system. Some practices have the facility to have those kind of voice recorded messages or choices, and some don't. So where that's available, we have recommended that that advice is put on, and we have done some checks ourselves through the contracts team. We've also looked at websites as well to make sure that the right message is there, because that can make a big difference to access rates by having that messaging correct. If there are specific details where people are getting stuck in queues, loops, then please let us know, because we can follow that up directly with the individual practice and see if there's anything we can do to remedy that with them.
Okay, because I think from a patient perspective, it's very, very frustrating, but it doesn't do the GP practice any good either if everybody's dissing access and the service that's given them when really they've not been able to access it.
A lot of surgeries do have drop rate monitors on the phone lines, so if there's a call that drops, somebody gives up, it does report that, so they can get that information, and we can often get it from BT as well. But all I would say is that because everybody does have a different system, it's not a simple one-size-fits-all fix in terms of the technical getting the message out, but the principle of making people aware when they're waiting, absolutely that needs to happen. And if there are specifics and specific practices that we need to address that with, please just let us know through the primary care inbox and we'll follow up with them.
Okay, thanks very much. Anyone else have any further questions? Randy?
Paul?
Yeah.
Hi, it's Councillor Wheeler. Hi, thanks, Andy. Is there a correlation, do you think, or is it possible to make a correlation between the length of time people are having to wait for GPs to answer, for surgeries to answer the phone, and the fact that people can't or don't want to use e-consult? Or is it just a coincidence and people phone GP surgeries anyway and they're busy because they are busy, as always?
I think the e-consult, it's been quite a success in some ways and a bit of a beast in others. There's been lots and lots of use of e-consult, and sometimes for things that it's difficult to deal with in primary care, not because they're too complex, but that it's not necessarily been something that you would usually provide treatment for or advice to. So e-consults kind of created a large volume of queries, which has sometimes hidden some more important presentations in terms of working through that volume to find the signal in the noise, if you like. I'm not aware that there's any correlation between the telephone access and e-consults. It just seems to have been high across the board, e-consult. And I think the telephone access issues have become more a problem of late as kind of, not that lockdown's relaxed, but people have become more active and getting back more towards normal. Also, the scope of primary care is extended under the standard operating procedure, so more things that were perhaps constrained in the past have come back on. So that's an issue that we do. In terms of that correlation, though, I've not seen anything that reports that, but I can always take that back and ask the question about what is that access like as part of the point that we've raised about people getting stuck in a loop.
Yeah, it's just I've got sort of two elderly friends, neither of whom, have ever had a computer in their lives. And, the normal procedure is to ring the GP practice, because there is no alternative for them. They're both housebound. And, it is so frustrating for them. I mean, allegedly you could, you can advise them to be patient and yes, you will get through, but it doesn't seem a very satisfactory answer.
No, and usually when we look at these things and map it, there's peak hours in the day where you can get hundreds of calls per minute into a practice, so you just get a big surge, and that can put people in a loop because it overwhelms the switchboards, because they're not in each practice. The switchboards aren't that big. You often only have like 4 or 5 lines in, and what can sometimes happen is people get pushed out into a computer system away from a line and get stuck in a bit of a loop. And if there's issues with those, it's helpful to know, because sometimes that indicates there needs to be a bit of an upgrade to the telephony system, or some change in messaging, or a revised messaging system so that people don't get stuck. And we usually have methods. So early doors, we identified patients who would struggle with email or e-consult, and gave them almost like VIP access So they were given specific access to get through that based on health need and ability to use the technology. So if there's anybody, again, that's stuck or struggling, we can sometimes help with that and usually get a change to make sure that people can access care.
Mm-hmm.
It's hard enough as it is.
Yeah. Yeah. Okay, thank you.
Anyone have any further questions for Simon? Sorry, for Andy.
Chair, sorry,
Yeah.
Lydia from Health Watch. Could I
Hi,
just hi? Can I just add? Councillor Sarah Hall mentioned Health Watch England's report around GP access for digitally excluded. I just touched briefly on the update report. Is that ECS are doing a report on digitally excluded. We are working with the PCNs at the moment, but obviously due to COVID, etc., I think that we're managing to work with one GP service in Warrington, and basically they will be patients will be interviewed, and they will be people who are aged over 65 who have a disability, and also English is not the first language, and people who have diabetes as well. So we will be able to hopefully report back on that, and possibly maybe be able to work with the CCG on this as well.
Absolutely. So I think I knew that was going on. It was any information we get like that en masse is helpful because it does help guide things.
It is a public health issue as well, though, isn't it? Because obviously access to services is a big issue, and if you can't actually get through the over the first hurdle, which is contacting the GP practice, then or you're being put off at that point because it's quite challenging to do, then the likelihood is that when you do present with symptoms, you're going to be further down the line, and that's so it is a really important part of the health system. And even a simple thing like a change in a telephone message might actually make a difference.
It does, and we've seen that in the past. And sometimes the systems just break, and if somebody's not checked recently that it's not putting out the correct message, then you can have a day or two where things just aren't working correctly. Most practices would check on a daily or bi-weekly basis to make sure that the messaging is correct, but in that intervening period, if it's broken, then sometimes you can just go off into a void. And I think so I would always say, if there's ever any of that, drop a message to the CCG, call pals, whatever, because we can usually get onto it within 24 hours and see if there's anything that can be done.
Okay. Any more questions for Andy? Okay. Can I take you back, Andy, to the Bath Street?
Of course.
Because there's a few things there that are probably worth exploring a little bit. Who were the stakeholders that were involved with the process, and were there any patients involved?
So the EIAs are done with patient focus groups, and we get input from service users as part of that service. We can get the detail of it because it was that work was undertaken quite a while ago, as the service was mobilised and the changes were deferred. Part of the more recent work around the contract mobilisation against the service, there was some work that was done regionally as well as locally to undertake it. So, and I believe that the EIA and QIA that was undertaken most recently was done locally, and that was January 2020. So we could get the list of stakeholders that were involved there. And as I say, we did discuss it through Health and Wellbeing Board back in November, that there was this policy shift, but there shouldn't be a change to service.
Right. So my concern, I suppose, and this is probably on the back of what we were talking about with the spinal services, was just the engagement or the communication with the committee or the council in general, and it was very disappointing from our perspective, both as a committee and I think probably the wider population, that this change was communicated to us via the local newspaper, and maybe the newspaper report wasn't as accurate as it could have been, and the message wasn't managed quite as well. So when we us better, and you were going to give airtime to any issues. And I would have thought that this would have been one of those issues that would have.
Oh. Sorry, Chair, I keep losing you for big tracts of time there. I don't know whether that's just me or whether.
So my point was that at the spinal services meeting that we had, we would communicate with us better and give airtime to issues that were needed. And I would have thought that this was one of the issues that, from a simple communication perspective.
Yeah, I can't.
I lost you.
Sorry. Yeah, I couldn't hear. I think I got the gist about why wasn't it raised. I think because it was actually something that was all done pre-COVID, and the ultimate return occurred in March 2020, so it wasn't something that was new. And on that basis, I probably wasn't aware that you didn't know that because it wasn't something that was a big change. It was about recontracting a service. So, as with all contracts, they expire at a certain point, and this contract was due for renewal, but had to be renewed on a regional basis. So the service itself isn't changing, which is why there wasn't a big engagement drive on that one, because it's the same service. It just needed to be recontracted with as part of a broader offer around integrated urgent care. That policy we discussed through committees, through Health and Wellbeing Board, in public meetings, but it all occurred over 2018-19, with the ultimate decision loop completed in March when that returned in 2020. But the mobilisation was deferred twice, once 1st of October and then to April this year, with contract extensions put in place with Bridgewater over that period. So it was it wasn't under the table, as it were. It was something that had been discussed, but probably quite a while ago compared to when it's mobilised, and that wouldn't be the case in ordinary times, because we'd usually move from that conversation through the contracting process to mobilisation, and we couldn't do that on this occasion.
Okay, and there's no other service changes that we need to know about that are going to be coming out in the local media that we suddenly seem to be blindsided by, either by COVID or other issues?
There should not be, Chair, no. I think that's fair to say, and certainly if you're blindsided, I would be too. But there aren't any other major contract shifts that I'm aware of that are going on.
Okay, thank you for that explanation. Thank you. Anyone have any further questions for Andy? Not at all. Okay, and then thank you very much, Andy. That then brings us to Warrington and Halton Hospitals. I know that you've already spoken on the agenda, but is there anything further to add, Simon or Lucy?
No, thank you, Chair. Nothing further to add from a hospital perspective this evening. Okay,
thanks, and thanks very much. Which brings us to the end of our agenda, apart from the work programme. But as you'll be aware, this is the last time that this committee is together before some local elections, so it's probably the very last time that this committee will be in its present state. So what I'd suggest is that we keep the items on the work programme and each of the topics, and we'll revisit them when the committee is reformed. But on behalf of the committee, I'd like to thank everybody for tonight, but also your ongoing support over the last however many years it's been with the Health Scrutiny Committee, and I'm sure we'll be back, or a number of us will be back after the elections. So I look forward to, hopefully, all being well and with democratic choice, seeing you again after the May elections. So thanks very much for your time this evening, and that brings the meeting to a close. Thank you.
Thank you.